Assalamu alaikum, the long clinical consultation day. First scenario, Mrs. Caroline Morgan, 63 years old, with complaint of back pain. Please take history, examine the patient, and address her concerns. Ready?
Yeah, I'm ready.
Okay.
All right,
Hey.
good evening.
Hi,
Good evening.
Hi, good evening,
Eh, Okay, Dr. Henry, one of the doctors here in this clinic. May I confirm if you are Miss Caroline Morgan, 63-year-old?
Yes, doctor, that's me.
Okay, I'll just go through your record and just see that you have been complaining of back pain. Is that so?
Yes, doctor.
Okay, can you please tell me more about this, your complaint, Morgan?
Yeah, I've had this back pain. It's been there for quite some time. I would say about 3 months now, but it became worse about 6 weeks. So I thought to get a check with my GP who referred me to you.
Oh, I'm so sorry to hear about your back pain. I know that it must be really difficult for you, but not to worry. We look forward to support you, in every step of the way. Is that okay?
Okay, doctor.
All right. The pain, where in particular do you feel it in your back, if you don't mind?
It's just in the middle of my back, the middle of the back.
Oh, okay. In terms of the severity of the pain, one being the lowest and 10 being the highest pain you ever had, which number will you put, this particular pain?
I'll put about 6, doctor.
6. Oh, so sorry to hear that.
Mm.
And does this pain, do you know of anything that made it pain worse?
Oh, if I move, it gets worse with movement.
Oh, okay. So sorry. What if anything I do that made the pain, better?
I can't really say exactly, doctor, but I know movement worsens. But if I stay still, it gets better.
Oh, okay. Does the pain spread to other parts of the body?
Yes, it goes around just feel it around my wrist and sometimes, just around my waist, around my chest, yeah.
I'm not so sorry. Okay. Have you taken any medication so far? That's for the pain?
No, just
Okay.
the regular paracetamol, which sometimes help.
Oh, okay. So if I'm asked outside this pain, sorry, do you have any other complaint?
No.
Pardon? Okay,
No.
Okay. All right. Do you have have you feel that you have any weight loss?
No. But my eating has just been fantastic, but I've not noticed that.
Oh, okay. Do you have any fever? Probably your body getting hot?
No.
Oh, okay. Any drenching night sweat?
No, doctor.
Okay. Do you have any contact with anybody that has been having prolonged cough for a very long time?
No.
Okay. If I may ask, sorry, do you feel as if probably you are getting tired or probably weak?
No.
Okay. Do you feel as if your eyes probably you are appearing like you're appearing dizzy?
No.
Okay. Any headache?
No.
Any seizure?
No.
Okay. Any loss of consciousness?
No, doctor.
Okay. Do you have any problem with your vision?
No.
Okay. Do you have any problem with your swallowing?
No.
Okay. Any loose stool or constipation?
No.
Any tummy swelling?
No.
Okay. Do you have any pins and needle sensation in your hands and legs?
No.
Okay. Do you have any neck
কি
swelling?
কলা কিন্তু কলাটা খুলি দেখো
No.
আগরের
Okay.
মতো কলা কিন্তু কলা
Do you have any temperature, like for any hot or cold intolerance?
No.
Any weight gain?
No, doctor.
Okay. Do you notice that probably you have lumps and bumps in your body?
No.
Okay. Do you also notice that probably you have, any issue of fall? Have you fallen, be falling down ever since?
No.
Okay. No. Okay. Do you have probably any injury behind at your back?
Oh,
Probably had
yes,
any.
I just think it's quite, well, about 7 weeks ago, I was in the bath and I slipped and hit my back on the
I'm so sorry.
on the wall.
So sorry about that. So sorry.
Thank you.
All right. Do you have any breast pain or swelling?
No,
Okay, any nipple discharge?
no, doctor.
Okay. If I may ask, sorry, have you probably are you on any medication that you have taken for a very long time?
Oh, yes.
Okay.
Yeah,
Can you tell me more about this medication?
I'm on steroid.
Oh, so sorry.
Mhm.
For how long have you been taking this steroid?
I've been using it for about a year now.
1 year. Okay. Oh, so
Mhm.
sorry. Did you just increase the dose of this steroid recently?
No, if anything, it's been reduced.
Okay. All right. So for what condition have you been taking the steroid for, if you don't mind?
My children may have polymyalgia rheumatica.
Polymyalgia rheumatica. Oh, so sorry. And then for how long?
So it was diagnosed about a year ago, and I've been on steroids since then.
Okay. Is the symptoms well controlled now?
Yeah, I think I feel better.
All right.
The steroid work magic.
Well, that's good. That's good. Do you have any other condition outside this polymyalgia rheumatica?
No,
Okay. Do you have any similar condition in your family?
you mean which of the conditions?
Like the polymyalgia rheumatica you complain about?
No,
Okay, any other maybe any other condition in your family, that maybe cancer or anything that is linked to your family?
not I'm aware of.
Okay. Do you have any, if I may ask, sorry, what of your waterworks? How's your waterworks like?
Oh, good.
Okay, all right. What of your partner? Are you living with are you currently married or you are staying alone?
I live with my partner. And we are
Okay.
good.
Okay. How's it affecting your daily life with your family?
No, I'm able to manage.
Okay. Is your husband supportive?
Yeah, very supportive.
Okay.
God bless
All
Mark.
right. Right, okay. Have you had any surgery before in the time past?
No,
Okay. What of your job? What kind of job do you do?
job. I work. Well, I'm volunteering in a shop now.
Okay. Is it affecting you? How is it affecting your job?
No, I'm able to do my job.
Okay. Do you smoke? Sorry, it's a little bit personal. Do you smoke?
Oh, yes, I do.
Okay. For how long have you been smoking, and how many sticks of cigarette have you been
No,
smoking?
I've been smoking since I'm 15, and I smoke about 10 cigarettes a day.
I think sorry to say, you may need to cut down. Have you ever think of cutting down smoking?
Oh, doctor, I've tried a couple of times. It didn't work.
Okay, don't worry. If you don't mind, I have to refer you to our smoking cessation clinic. They will help you to go through it. Is that okay?
Yeah.
Okay. Well, can you tell me, if I may ask, are you still menstruating, or you've stopped menstruating?
No, I've stopped menstruating. But doctor, I'm
Okay.
63.
Are you on any hormonal replacement therapy
No, I hate that
or
shit.
pills? Okay, okay. You see, if I may ask, do you any recent travel?
Travel? Yeah, I do.
Yeah. Okay. One of the last time you traveled to what happened in the course of your travel?
I didn't quite get the question, doctor. Can you say that again?
When was the last time you traveled, and what was your mission for your travel? Sorry, if you don't mind.
Mission for my travel. Yeah, I travel with family during summer. I went to Spain.
Okay. Do you have any contact with anybody coughing there for a long time?
No.
Okay. All right. So if you don't mind, are you on have any drug allergy?
No.
All right. Can I examine you if you don't mind?
Oh, sure, doctor.
Okay. First of all, can you be able to walk for me?
I actually can walk normal
Okay.
gates.
Just come on. Okay. Can you please can I see your hands, please?
Yeah.
Therefore, if any finger clubbing, any pallor,
No.
dehydration, look at the hands. Check the pulse. How is the pulse like?
70 beats per minute regular.
Okay. Then the BP normal.
120 is 80 minutes of mercury.
Okay. Then check for the pallor. Any pallor?
No problem.
And look at the mouth. Anything in the mouth? Anything in the mouth?
No,
Look at the neck. Okay. Look at any pededema. Okay. Then go to the back and look at the check anything in the back. Any swelling there in the back, in the spine? Anything?
no deformity, no swelling.
Okay. Then check. Look at the joint. Can you do and check for your prayer sign in the hands and check for anything like that? Okay.
No more.
Okay. Okay. Then all right. Then go to the front. Then also check, look at your heart, and then palpate the apex beat. Check for the heart soreness too. Anything.
No.
Okay.
No more
Then
at
go to
all.
the tummy. Examine the breast and see. Go to check the breast. Do you mind if I examine your breast? Sorry.
Oh,
Check all the
doctor.
contents of the breast. Okay. Then any nipple discharge, nothing. Then go to the tummy and check for any organomegaly. Nothing there.
Nothing.
Okay. Okay. Then can you do a postnatal drift for me? Then raise your hand up and then let me check. Okay.
Okay.
Your gait is normal, right? After night, when you walked, your gait was normal, right?
Yes, it was normal.
Okay. So just to ensure that we are in the same page, you said your complaint started 3 months ago with when you had a fall, a sleep in the bedroom and you fall down, right? And so then you have been having pain, which has been, affecting your wind and the. Have you had any weakness? Sorry.
Weakness.
Yes, of the leg.
No.
Okay, no weakness. Okay. So you also mentioned that it's the pain moves towards your chest and then towards your waist. Is that not?
Mm.
And you also said that you had condition polymyalgia rheumatica and you are being on steroid. Now you have been tapering the steroid. If you don't mind, is that so?
Yeah.
All right. And no family issue of similar condition. Okay.
No.
And no weight gain, no weight loss. Okay. No. Okay. Hey, thank you very much. We are looking at okay. And check for all the points of tenderness for the polymyalgia rheumatica. Check for in the shoulder. Check in the hip joint. Check any points of tenderness. Nothing. Okay. All right. If you don't mind, did you have any concern?
Doctor, what's going on with you?
That's a good question. Looking at the issue of fall that you have because of the steroid you have been taking for this polymyalgia, I'm of the opinion that you may be having what they call osteoporosis. Is a condition whereby there's the bones in your bones are kind of fragile because of this most likely because of this steroid you have been taking for close to 1 year now, and that is the reason why it might have caused this the fall that the sleep that you sleep in your bedroom that fell probably might result to because of the bone fragility, the bone being so fragile, being so loose. That is why we developed that. This is what I'm thinking. And also, I'm also looking at because also other likely cause too, which may include what they call Paget disease of the bone too. Is also another condition too that is linked to your age group and things like that. However, I'm also looking at could you also be what they call multiple a condition called a kind of bone condition called multiple myeloma. But in such a case, it's because of you don't look pale. So we're certainly going to rule that out. And also, I have a lot of things in mind. But basically, the first thing I have in mind is the osteoporosis. And because of that, we may need to do some blood tests for you,
2
do some
minutes left.
scan too, do some scan, which we call DEXA scan, and then some other things, then your bone profile. At the same time, we need to, refer you need to see a doctor that works with bone. At the same time, we'll see how we can give you some follow-up and then give you some medication and advice you on the next step. Is that okay?
Yeah, it's okay, doctor.
Any other concern?
Doctor, why do you think I have this?
That's a good question. Like I said, it's more like because of the prolonged steroid you have been taking for a very long time. That is more like a risk factor towards that. Any other concern?
Okay. All right. Is there anything that you think I can start doing that could, because you will say my own issues, anything I can start doing while you do the investigation? Because I'm quite worried about cancer.
Yeah. At this thing, do you drive? Sorry.
Yeah, I do drive.
Yeah, at this point, I may need to, because of the pain and because your structure, because that you may need to, for now, stop driving now because because of the pain you're having, that might cause a little bit of discomfort while driving, and also we need to do some bone tests for you, for now to really confirm if that's what you have. Then subsequently we'll manage that. Is that okay?
It's okay, doctor. It's okay. And you
Any
think
other concern?
You think it's not the cancer? It can be.
It's a possibility. We need to rule that out too. Like I said, you need to examine your breast and then your ovaries and the other side, then it's also a possibility. We have to also consider that. But for now, what is topmost of my differentials of my likely cause is the osteoporosis, like I mentioned. Is that okay?
Oh, that sounds good to me. Thank you, doctor.
Okay,
Right. Yeah.
time is up. Questions? Dr. Ayoda, please.
Doctor, Dr. Henry, can you present your case, please?
I presented Miss Caroline Morgan. It's a 63-year-old woman who presented on account of 3 months history of pain, back pain at the middle of the back, which radiates to the chest and also to the wrist level. Following an episode of a sleep from the bedroom, he had a history of polymyalgia rheumatica, which was diagnosed a year ago, and she has been on steroid for that. No family history of no history suggestive of no other history. The other history are not significant. However, on examination, there's no obvious. When I checked, no obvious tenderness at the back, and no other systems review are generally not a contributory. Looking at my history and differential diagnosis, my history and examination is she's having a condition called osteoporosis due to the steroid she has been taking. Other differential diagnosis in this case may be due to cardiac disease of the bone, and also may also be due to malignancy from query metastasis from either any of the organs. However, not query organ specific, that the breast of the ovary. However, nothing to suggest that was seen on breast examination. Also looking at also it could be also multiple myeloma, but in this case there's no evidence of pallor and no evidence of urine problem. But I have to investigate towards that line. Also, as part of my investigation, we need to admit my patient. I need to do some tests, including full blood count differential diagnosis, full blood count and differentials, electrolytes and urea. You also we do bone studies such as calcium, serum calcium, alkaline phosphatase, parathyroid hormone, and vitamin D. Also, schedule her for DEXA scan, in which I then took DEXA scan. I also do X-ray of the bone, of the thorax, thoracolumbar X-ray, and also want to do generally do other antibodies such as CA125 to rule out any breast CA, and then also send my patient to do mammogram to rule out and then CT abdomen to also rule out pelvic any abdominal tumor. Then to manage my patients, management of this patient may include a multidisciplinary approach, which involve the rheumatologist, the orthopedics, the physiotherapists, the specialized nurse, and also the occupational therapy. I'm going to following the investigation done, I'm going to counsel my patient on the likely diagnosis, which in this case is more in keeping with osteoporosis. And then if looking at there's any evidence of fracture, or we may need to start on bisphosphonates, which we either the alendronate. If she doesn't respond to that, we need to commence on palmindronate or solindronate. However, at this case, we need to also discuss that with the rheumatology doctor. Will also be involved in this case for that to advise her on the need to taper the steroid, and then if possible change to other non-steroid other non-steroid immunosuppressants for her. And also we need to involve regular monitoring, and then other steroid assisted therapy like calcium, calcium with admission of calcium and vitamin D if need be, and then also counselor on need for visiting her for continued follow-up and physiotherapy workup. Thank you very much.
Thank you. So what are the advice that you are going to give to this lady?
Yeah. the advice. Okay, the advice is I'm going to advise on the avoidance of trauma, avoidance of hard chores at home, and the use of aid in terms of to prevent sleep. Working working aid also, and then other advice to avoid steroid and also weights to avoid other causes of osteoporosis, which may include avoid hormone replacement therapy, and also other forms of other risk factors in this case of osteoporosis.
Okay, thank you. Well done, Dr. Henry.
Okay, I will
Thank
ask
you.
him one more question. What precaution for bisphosphonate you have to advise?
Yeah, for the if I to comment on bisphosphonate, we want to advise her that when she's taking the drug, she needs to ensure that she take a lot of water, because they are risks of coming down with vasculitis, and also within 1 hour she should not ensure that after she take the drug, she position herself, and then she should not lie down immediately after she has taken the drug to avoid osteoporosis. And then also if peradventure she has any complaint with her swallowing, she should come back and see us for change of medication.
What other medication you know for osteoporosis?
Yeah, other medication may include teriparatide, also aloxifene, basically, and then denosumab. So basically, if they don't respond to that.
What the advantage of denosumab over the bisphosphonate?
For people that have malignancies, usually malignancy as a cause of the bisphosphonate, denosumab has a more advantage in the sense that it can help to prevent further. It's more superior to bisphosphonate in certain of malignancy, basically.
And kidney function.
Renal function, basically.
And the frequency, it's once Q6 months, right?
Yeah, once a month.
Okay, Dr. Ayula, you can comment now, please.
Okay, well done, Dr. Henry. You did well. Let's start from the history. You did well. You have important history. Just some things that I noted down in the history that were pertinent that you did not ask. This patient has a back pain. It's been going on for some months, and what gets was about 6 weeks ago. But she fell in the bathroom about 7 weeks ago. Excuse me. We then try to explore for pain in any other joint of the body, or in any other joint, which is quite important. Having pain in other part of the body as well, which she might not have, taking conversant of, which would also help in looking out for any other possible cause, systemic cause of this pain. It's sort of a localized cause of back pain. Okay, then it is important to also know if this pain is sufficient to disturb our sleep. If it's worse at night, that will give you an idea of what it is. And sometimes malignancy pain sometimes could be worse at night. And another important thing that you missed in this patient is respiratory symptoms. This, like, we are aware that one of the common cancer that spread to the bone is the breast, the lungs, prostate in men. But you missed out respiratory symptoms totally. But in this patient, I've been having back pain, and it is every smoker. It's quite important that you missed out in this patient. So other history wise was quite good. You'd ask a lot of questions in the other part of the history. Examination wise, you check this patient's gaits, which is good, but you did not examine the lower limb as a whole, which is something that is quite important in this patient. You need to examine the lower limb, check for the power tonal reflexes, and also check for the sensory examination. Since the pain is in the thoracic region. Another thing that I felt a bit uncomfortable with is you wanted to examine this patient's breast and just say, I will examine the breast. I felt odd somehow being a lady at the same time. I felt like no, there was even just is it all right? You just talk to the patient like take some permission, like just make her a bit comfortable with you. I didn't feel comfortable with the way you act. How much asked me, so how much more like a patient thing. So I just felt like the way you act is quite important to examine the breast of this patient. Very, very important because of her age and her symptoms. But the way you went about it was some I felt a bit odd. Then the investigation was also good. You talked about a lot of investigation. When you were communicating with the patient, you were so certain it's osteoporosis. Fine, osteoporosis is high at the diagnosis. Even your management line, you went down through the osteoporosis line, which is good. But in this 63-year-old lady that has, though he has a high risk of osteoporosis, she's a smoker, which you did not address at all. When you were talking to the patient and when you were talking to the examiner, you did not address the smoking issue. Though you told her that it should stop, but you did not further emphasize how important this is and why she needs to stop in this patient when you were having conversation with her. Then I've lost my stream of thought, excuse me. Yep. In this patient, that was one thing I noted about this. You were so sure that it is osteoporosis. I think you just need to be diplomatic with the patient. Something like from all that we have discussed and the examination findings, there are a couple of things that is going through my mind, and osteoporosis is one of it. But it is important that we look out for other sinister things like cancer of the bone and also spread of cancer to other part of the body. Let the patient know that and when you were managing talking to the examiner, need to let the examiner know that we also need. Do you mention all of those, the CA125, which you said for breast? I'm sure it's because you were rushing, you were speaking quickly, or of course you and I know that it's not for breast, it's for ovarian. And just let the patient know that you will do immunoglobulin, do electrophoresis if that is the case, because you are thinking of a multiple myeloma. Though you did mammogram for the patient, which is quite important. Then CT tap, MRI spine. I'm not sure I quite heard you say that. Though you mentioned you did this DEXA scan, which is quite good in this patient. Apparently, this to be osteoporosis, but you don't want to stick your neck to osteoporosis because it could be something else that we are sitting on, and you did not examine the lower limb of this patient, which I found that is quite important to do in this patient. Then the risk management, you said ask patients to avoid steroid. For patients that have PMR, when I asked for what advice are you going to give me, you said avoid steroid. For patients that have PMR, I don't think we need to say that. Though you mentioned along the line that you get the rheumatology involved in his skin care, which is quite good. And what have I been to say? Yeah. Then advice of osteoporosis diet. You didn't mention anything about diet. Eat food that rich in calcium. Sun might also help you. Okay, so I will advise you. Some people advise that you walk in the sun, in the house, especially if you are in the UK. That sun is quite far away from the UK. Between 11 and 1 o'clock, so they said it's okay to walk around that time to help you with get as much get from that. Then avoid smoking. We need to emphasize on this patient why she needs to avoid smoking. So yeah, basically that is all. But all together, you did well, and you mentioned some of the risks associated with some of the management. I mean, you talk about the management of osteoporosis extensively. Well done. And then follow up, please. This patient does not need admission, obviously, but you need to talk about following her up with even if she's on steroids, if she comments on bisphosphonate, you need to keep doing DEXA scan for her yearly to see the response to it. And at the point, I think after 3 years or so, you need to stop. I'm not quite sure, but you need to just keep doing follow-up with DEXA scan for her and monitor her calcium and phosphate level as well. Thank you. Well done, Dr. Henry.
Okay, thank you, Dr. Ayula. I will summarize quickly what Dr. Henry missed or mistaken he did, and yeah, we will move to the next slide. So the first thing for the history, regarding the history taking, the part of neurological manifestation or red flags or alarming signs of back pain, I think he mentioned the pins and needles. However, he missed the other neurological like weakness, lost the control over the bowel and water work. Why? It's important because it might be as indication for urgent intervention by neurosurgeon, right? We know this is not a case of osteoporosis only. It's a osteoporotic fracture because osteoporosis will not cause back pain itself. But when the fracture happens, now the pain will be there. So he has to take the alarming history of alarming signs or symptoms of weakness or the back pain, which is the weakness, the legs, or numbness, the legs, along with the loss of control over the bowel and water work. Yes, the severity of the pain was there, and he should be admitted to the hospital because of that pain, plus the alarming sign if it's there. Otherwise, the past medical condition, for me, I could and I would like to take it earlier before the system review. Anyway, everyone has his approach, but at least he got the steroids. Some candidates, by the way, some surrogates, they are not giving the steroid as a medication or history of medication. So if you ask and he said no, tell him show me your medication list. It must be there, and he will think that this is another medication which is long time medication, so no need to mention it. Okay, sometimes also you have to mention it by name. Do you take any steroid? Otherwise, you might miss the case. Okay, back to the examination and history. I think taking history or doing lump or breast examination is inappropriate in this scenario. Even the history. If you want to roll out, you mean lump, right? I think he asked for the lump. This is the main aim of breast question. You want to roll out breast cancer as a original cancer and with the back mets, right? I think so. At least take the history, or if you want, offer it. Don't go direct to the examination because it's clear, straightforward case to the steroid or the steroid related osteoporotic. And after trauma, the fracture happened. Okay. Back to the other risk factor like smoking. Yes, you have to give strong advice to stop smoking. It's one of the risk factor that can lead to this condition, along with the sun exposure, the diet habit. Maybe the patient is not taking balanced diet, and the sun exposure as well. The driving is irrelevant at all to ask about stopping driving, unless, and this is very important, you have to do it, to ask about vision issue related to polymyalgia rheumatica. I will ask Dr. Henry now, what is the condition the vision will be affected in polymyalgia rheumatica?
In polymyalgia rheumatica, sometimes it may tend to have something that looks like a giant cells arthritis, manifestation.
Yeah, perfect. So
Kind
it's
of.
giant cell arthritis. By the way, you have to ask about the condition itself. Is it controlled? Do you have any stiffness? Along with the examination, can I examine the stiffness of the shoulders and the pelvis? Okay. Along with the scalp pain, you have to ask straight away whenever you have a condition in the past, in the history, you have to ask about it. The same as for diabetes. You have diabetes, yes, doctor. How is the diabetes? How is the control? How is the hemoglobin A1C? The same here. You have a condition which is called polymyalgia rheumatica. How is it? Is it controlled with the steroid? Any relapse? Do you have, or if ever you have vision loss, pain at your eye, pain at the scalp or the face. And during examination, you can also do the examination of this part, the shoulder. Even you can offer eye examination and the claudication of the jaw, right? It's related to the giant cell arteritis and temporal artery arteritis. Otherwise, as an examination, this is instead of examining the breast. So if you want to examine something here, you will examine the shoulder as well as the face for the scalp and tender point. Otherwise, you did perfect. The examination of the back, also you did. Look, feel, move, always you do. And check for tenderness, redness, hotness. And the power in the legs is important to do. At least one power distal and one proximal. And the sensation, one superficial, one deep. That's more than enough. I'm not sure also about the differential as multiple myeloma. If you don't have kidney issue, if you don't have pallor, why you put as a differential? However, you have to rule it out. But don't mention to the patient. You told her about multiple myeloma, right? You scared her about this condition. And she asked you, doctor, later, do I have a cancer? If she asks, do I have a cancer? You can tell her about possibility. But don't tell her about this possibility by yourself. Okay?
Yeah.
Yeah, it's straightforward for the osteoporotic fracture. And by the way, it's not osteoporosis only. You have to say osteoporotic fracture, particularly after the trauma. And give her some rest, sick leave if she's working. But here, I think she's a housewife. Tell her about bed rest and improve the diet habits. Okay? Dr. Ayula, anything missing or you want to add?
No.
Okay, so the differential here will be mechanical back pain. First of all, osteoporotic fracture. You can add osteomalacia as well as bone or multiple myeloma with bone mets, osteolytic lesion, or disc prolapse. This patient had a trauma to her back. So disc prolapse also can be as a differential. You can put it instead of osteomalacia. Okay?
Okay. But my issue with the
Yes.
disc prolapse, sorry,
Yeah.
the there's no, because when I ask about the history of pins and needles, he
Yes.
doesn't have. Then when I ask him to walk, and I also have about the history of weakness of the legs, he doesn't have weakness of the leg. When I ask him to walk, it doesn't work. So those things tend to kind of downplay the disc prolapse. I don't know if I'm. That was why I kind of before I took the history, I have about 15 differential diagnoses I put in this
Oh,
back pain.
nice.
Yes,
Yeah.
but
That's
I was
why.
trying to rule them out. All of from TB to
Yeah, by the way,
osteoarthritis.
it's
Many of
good.
them. I was
It's good to
sarcoidosis.
put
Yeah.
perfect. It's good
Mm,
also to rule out TB by the question of do you have
yeah.
any contact with sick patient? It's
Mm,
very good question.
yeah.
Why
So
Potch disease? One of the possibility. You're right.
mm,
I agree 100%. But if
then
you want to put as a differential, Dr. Henry, I said it last session.
mm,
If you want to put differential of joint pain, write the three categories of any joint pain: mechanical,
mm,
or inflammatory, or septic
mm,
arthritis. So by this
mm,
way, you save the time. You will not write a lot of differential. Yes, you have to know what are the most common in the inflammatory, like
mm,
seropositive, seronegative.
mm,
Okay.
yeah.
What are the most common in mechanical? Like our case is osteoporotic fracture, trauma, and osteomalacia, gouts, for example. And for the septic arthritis, yes, you have to
Mm,
rule it out in every joint pain, but not in our scenario today. By the way, discitis is also one of the cause of mechanical back pain. Discitis. So you have
yeah.
to have
Yeah.
in the history
Mm,
exposure or any procedure recently or cannula or infection, which patient had antibiotics for it, received the IV medication recently. Okay, you can put it also as a differential, particularly if you have weight loss, if you have fever, if you have night sweats. Okay, yeah,
mm.
that's it.
Right.
But
Thank you.
don't
Thank you
write
so much.
the whole Back pain differential 15. You waste. You have 5 minutes before going to the station. Okay. If you will write the 15 differential and roll out of all of them, you will waste the time. How to save the time?
Okay.
Write the main type or the classification, as I said, the inflammatory and the mechanical. Then you have to know what are the most common in the inflammatory and what are the most common in the mechanical. Then proceed with the approach, your approach, whatever your approach is good, by the way. You did the from the history, the yes, the constitutional symptoms, then the system review, but I prefer to put the past medical history before it. Any past medical
Okay.
history I should be aware of, medication, surgical, allergy, over-counter medication. Okay?
Yeah.
Yeah.
Another thing, just to add, like some things I didn't do that I would have done in this patient too. I should have also when I asked about the pain, I should have asked her if she had had any pain like this previously in the time
Yes.
previously. I should
Yes,
have
sir.
also asked, because that's to know if there's any if it's more like a recurrent pain she has been having. I didn't ask that too. And also, like what she has said in terms of the some review too, I didn't even establish, even my cardiac review was not okay here.
Yeah,
My
yeah, yeah.
CVS was not
Yes.
so good.
Yeah.
Definitely I just observed that too. Thank you very much, Chief
Yeah. So
Mazen.
please
Thank you very much,
improve
Dr.
the
Ayala.
system
Thank you
review.
for that.
Most welcome, Dr. Inari. The
Yeah.
system review,
Mm,
start imagining the patient in front of you from
mm,
head to toe. The
Yeah.
head, you mentioned you did every
Mm,
system. I think you missed
Yes.
only the respiratory and the
Yeah.
cardiac.
And cardio. Yeah.
Yeah, but
That's
but
true.
the other you did.
Mm,
So whenever you start to screen the body, imagine the body in front of you, starting from
mm,
the head, CNS, the endocrine,
Yeah.
as you did, then the chest, cardiovascular, then the
Mm,
GIT or gastrointestinal, then the genitourinary, and the
mm,
female history or the intimacy in the young patients,
mm.
and the extremities for musculoskeletal. This is
Thank
the
you.
way how to do it in perfect way. You will not miss any system. Okay.
Thank you. Thank you.
Okay, most welcome. Any question else? Any added point, Dr. Ayla, you want to add?
No, thank you. No.
Okay, second scenario. 55 years old, Mrs. Doreen James, presented with fatigue. Hemoglobin is 9.6. The platelet is 55,000. I think it can narrow your differential by the lab's results. When you're ready, let me know.
Mhm.
Please, others can input the differential for the second case. Yeah, the scenario. Okay, Dr. Muhammad.
Yeah, we can start.
Okay. Dr. Muhammad, as you are active, I will ask you about your differential after this session, if you would like to share. Okay. Yes, Dr. Ayula, here you go.
Hello.
Hi, doctor.
Yeah, my name is Dr. Ayola. I'm one of the doctors here today. Can I confirm you are Mrs. Can I confirm you are Mrs. Doreen James,
Yes, doctor.
55 years old?
Yeah.
Okay, is it okay if I call you Doreen?
Yes, doctor. That's okay.
All right, good. So I understand from your note that you've been struggling with some tiredness. Is that right?
Yes, doctor.
And
I have.
also that you've had some blood tests done. Are you aware of
Yes,
this?
yes, I've not seen the result, but I did some tests. Yes, doctor.
Okay, all right. We're going to discuss about this test shortly. But could you tell me more about this tiredness that you've been having?
Doctor, for the past, 6 months now, I've been feeling so tired, so weak, I don't know what's wrong with me, doctor.
Oh, I see. And could you tell me how long, exactly how many weeks, how ago you've been fed? When exactly did you started?
Yeah, like I said, 6 months, doctor, for the
Six
past six
months
months.
ago.
Yeah, 6 months.
Has it been
I don't know.
worsening since then?
Yes, doctor, it has been worsening, doctor. It has. Yeah.
Okay, and this weakness, is it associated with any time of the day?
Not at all, doctor. Both morning and night, I feel it. Yeah.
Okay, what are the things that you've been doing before? I know that you cannot do anymore. Is there anything like that?
Not precisely, just that I just feel weak generally, this tired. I'm always tired. I do small things, I'm just tired. I'm always tired. But I see do the things I used to do.
Okay, all right. And is there any condition that you've been managed for prior to this time? Is there anything that
Not at all, doctor, no.
that you have? Okay. Right. I just want to ask you a few more questions about all this tiredness, okay? Have you got any is there anything that you think makes this tiredness better?
Doctor, I don't know. If I rest, I don't feel it, but when I walk, I just feel tired. Nothing. No, doctor.
Nothing exactly. Okay. And have you got any joint pain?
Joint pain? No, doctor.
Any rash on your body?
Yes, I do have this rash on my, I do. I have this rash on my back.
Where exactly is the rash?
Just on my back, just close to my scapula there.
Okay, all right.
Do you want to see?
Yeah, sure. Can I have a look at this rash?
Yeah, let me send to Dr. Bazim if you can.
Okay.
Send it to the rash. Sorry.
Yes, absolutely. Yes, you can.
How long ago have you had this rash?
It has been there, doctor.
Okay, does it come and go, or is always there?
It's there. Look at, I feel, it's there, doctor.
It's always there. Okay. And have you had it before this time? Or have you had it in the past before?
No. This the rash has been there for the past, within 3 months or there, but I started having that, and it's itchy, so I'm scratching it, doctor.
Okay. And it's itchy as well. Okay.
Yes, you can see.
Is it bleeding?
Well, I can't see it because it's my back, but sometimes I feel the redness in my finger when I scratch them.
Okay, all right, good. Okay. All right. So any bumps in your body?
No, doctor. No, doctor.
Any fever?
No, doctor.
Any change in your weight loss or weight gain?
Yeah, doctor, I've been kind of, my weight has not been getting, I've been reducing, looking as if I've lost some weight, but not so, yeah.
All right, I see. Diet like?
Pardon?
Your diet.
My diet has been okay. It has been good, doctor.
Yes, I'm doing good. Okay, all right. And are you aware of your heartbeat?
My heartbeat? No, doctor, I'm not.
Any shortness of breath?
No, doctor.
Shortness of breath. Okay. Could you tell me, how's your bowel like? Any concern about your bowel? Any pain in your tummy?
Pain in my tummy? Yeah, I feel pain. Yeah, I feel pain. Yeah, I have pain in my tummy, doctor. Yeah.
Okay, where exactly is this pain? Can you
In
point
my
to?
tummy.
Is it
Just in my tummy. I
everywhere?
can't really. Yeah, just in my tummy. Yeah, I feel this pain in my tummy.
Okay, and how is this pain like? Is it, could you tell me how the pain like? Is it something that is squeezing?
It's just dull.
It's
Just
just
looking dull, doctor.
Does it comes and goes or is always there?
Yeah, it comes and go,
It
basically.
comes and goes. Okay, is there anything that makes the pain worse?
I can't think of anything, doctor.
Like maybe like diet or things like that?
I can't think.
Can't think of anything. Okay, all right. And on a scale of 1 to 10, what will you score the pain? 1 being no pain and 10 be the highest pain you've ever had?
I'll give it 6.
You give it 6. Okay. That's it. How is your bowel like? Any issue with your bowel?
My bowel. My bowel has been. Yes, my bowel has been good. But sometimes I do have some. The time I look at the bowel when I went to the toilet, I feel there's some dark stain in my bowel.
Some dark point in your bowel. Okay. All right. I'll see. Okay. Does it look like blood to you?
I don't know. I know it doesn't, but it looks dark. I don't know if it's due to the kind of food I'm eating. I don't know.
Okay.
Sometimes.
It's dark. Okay. You should talk about food. Has there been any change in your diet? What food do you eat exactly?
No, I eat. I usually take food from this already made food from the Tesco, from the shop. I eat more of ready made food. So.
Okay. Have you ever had blood in your poo before?
No. I've not seen any blood. No. Just some
Never
dark.
had blood.
No.
Okay. What about your urine? Any problem with your urine?
No, doctor. My urine has
No
been
problem
fine.
with your urine. Okay. Any pins and needles anywhere in your body?
Pains and needles?
In
No.
your hand and foot. Okay.
No, doctor.
Okay, nothing of such. Okay. All right. You told me you don't have any medical condition you've been managed for. Is that it?
No.
Are you on any medication at all?
No, doctor.
No medication? Okay. And do you have any family history of any medical condition as such?
No, doctor.
Okay. And have you any family history of cancer whatsoever, not to alarm you?
Oh, no, doctor, no.
No. Okay, all right, good. So, do you have headache?
Headache? No, no,
Mm.
doctor.
What about your vision? Any problem with your vision?
My vision is fine, doctor.
Vision is fine. Okay. Any difficulty with swallowing?
Swallowing?
Mm.
No, doctor.
Okay. Have you noticed any change in any hair loss?
No, doctor.
Okay. And have you noticed any change in your mouth, maybe darkening around your mouth or inside your mouth, or any spots?
No, doctor.
Nothing of such. Okay. Any neck swelling?
Next one, no, doctor.
Any weather preference?
No, doctor.
No weather preference. Okay. And are you okay? Are you coughing?
No, doctor.
Okay, all right. So I just want to ask you another question about your health generally, okay? Do you take alcohol?
Alcohol? No, doctor.
What about smoking? Do you smoke?
No, doctor, I don't.
You don't smoke, okay. All right. What do you do for a job?
Doctor, I work. I'm a banker. I work in the bank.
Okay.
Mm.
And how has this affected your job?
Doctor, it has been. I've been feeling tired. Sometimes to go to work these days is getting boring to me because I'm tired, doctor.
Oh, that's it. Not to worry, we would look at it and see if it's something that we can give you a sick leave or to give you time for us to investigate this further and make an appropriate diagnosis. Is that okay?
Okay, doctor.
All right. Okay, could you walk me through your diet, Doreen? How is your diet like? Could you walk me through your diet, like what you eat on a regular basis?
Yeah, I eat canned food. I eat processed food from the shop. Basically, yeah, and that's I don't like cooking, so I usually buy already prepared food, and they're okay, good. I don't eat expired food. I eat, yeah,
Okay, all right, good. All
basically.
right. Is there anything that worries you the most?
Doctor, what do I have, doctor?
Okay, that's a very good question, Doreen. But is it okay if we examine you and then we can be able to, we can able to see what's going on exactly, okay? So
Okay,
I
doctor.
want to look at you, look at my patient from head to toe, then check the pulse, check the hand, any deformity in the hand, any telangiectasia on the fingers, nothing of such. Okay, the pulse rate, what's the pulse rate like?
Pulse rate is normal.
It's normal. Okay. And there's no tachycardia, right?
No.
Okay, all right. I check the blood pressure of this patient. I look at the
Pressure is
JV.
normal.
Okay, so my JVP is it elevated?
No, it's normal.
Okay, so I examine the cardiovascular examination. Any murmur on the heart?
Mama, no, mama.
Okay, is the patient pale?
Yes, patient is pale. Yeah.
Okay, any jaundice?
There's jaundice. Yes, there's jaundice.
There's jaundice. Okay. All right. So okay. So I just want to look at this rash again on your back, which I've seen is bleeding on the back. Okay. So I want to examine your tummy as well. Let me look at your tummy.
Okay.
Any tenderness, any swelling, any mark in the chest?
There's swelling in the left hypochondria.
Swelling in the left hypochondria. Okay. So
Yeah.
I want to examine. Okay. Any tenderness?
Yeah, it's just swelling, no tenderness. It's just swelling.
No tenderness. Okay. Examine
Then there's tenderness at the what do you call it, epigastric region, epigastric and the right hypochondrial region down. Then there's swelling in the left abdomen.
in the left abdomen. Okay. So
Left hypochondrial region. Yeah.
Okay. All right. Good. Thank you. So is liver enlarged and the spleen?
The liver is not enlarged. It's not enlarged.
What about the spleen?
Yeah, that is I don't know if that is the spleen, but now there's something that's enlarged in the left part.
Any
Part
notch?
of the organ.
Is there any notch
Yeah,
there?
you can feel it. Yeah, there's no specific notch. There is.
There's notch there. Okay, all right, thank you. So I want to listen to the bowel. Any ascites? Then I listen to the bowel sound. Okay. So I also offer to do a digital rectal examination for this patient.
Okay.
All right. Thank you for allowing me to examine you, Mrs. Doring. Okay. You spoke earlier that you are worried about what exactly might be going on, isn't it?
Yes.
Putting all of this together, because you had an investigation earlier, blood test, and the blood test came back, which shows that your blood count, okay, is low, and with the symptoms you have, and also with my examination findings, I could feel that you have some swelling in your tummy, and as well maybe some organ enlargement as well, and the rash on your body, and your eyes is pale, and also have some illness of your eyes. Put all of this together, I'm thinking that there's a lot of things that is going through my mind, okay. But the possible thing I'm thinking might be that you might be having some issues with your bone, what we call like by the way, Miss, have you had any form of radiation therapy before? Just
Not at all, doctor. No.
oh, okay, all right. And have you traveled abroad possibly recently?
I traveled, but not really abroad, but within the United Kingdom. Anyway.
Okay.
Yeah.
Okay. Do you have any flu-like condition recently,
No.
like sore
No.
throat and things like that?
Like what?
Sore
Sore throat.
throat and things like that before. Okay, all right. So putting all of this together, I'm thinking that you may have something like depression of your bone, what we call like something like a myeloproliferative disorder. It is affecting your
Okay.
bone to produce a lot of cells, and that may explain why you are having these symptoms. But we will further investigate you to see exactly what is going on. Then we can take it up from there. Is that okay?
Okay, doctor.
But I also, do you have any other concern at this point?
Doctor, will I get cured?
With what?
Will I get cured? Will I
Two
get?
Yeah.
minutes
Is it
left.
curable?
Yeah, in the
Is it
first
curable?
instance, what I would advise is that if it's something we want to do, is that we would want to admit you first because of this low blood and also because of this tiredness that you are having. We want to see if it's something that we can give you some blood to help you with that, okay? And then we would invite the specialist in bone to come and look at you in blood and come and look at you. They will further assess, do some tests, possibly we'll do some scan to look at exactly how extensive is this thing, is this condition, and also make a diagnosis and look at how extensive it is. They could possibly do some bone test for you as well. After then, we'll sit down again, look at the old test, and then we can be able to discuss the treatment plan, whether it is something we can cure, something we can treat, or something we need to manage, depending on what it is. But not to worry, we will try as much as possible to help with your symptoms and offer you the best that we can do. Is that okay?
Okay, doctor. Thank you so much, doctor.
Is there any other
Thank you.
concern? Any other concern?
No, doctor. Thank you, doctor.
Okay, all right. So are you happy for the admission? Is something you want to consider?
Yes, doctor. I'm willing. I'm willing.
All right, okay. All right, good. Thank you. So we would do what we can do to help you, okay? I'll also give you some signals to give to your employer about this.
Okay, thank you.
All right.
Thank you, doctor.
Thank you for
Thank you,
speaking
doctor.
with me today. So I will see you again later.
Okay. Thank you, doctor. All right. We are done.
Okay, the examiner question, Dr. Henry.
Okay. So can you please present your findings of your patient and likely diagnosis, investigation, and management?
Okay, I've speaking to this 55-year-old lady who had the previous blood test of which shows low hemoglobin and platelet count, and also presented with worsening fatigue of about 6 months. Apart from this, she has rashes on her back, which are quite itchy. On further questioning, she does. I will not pick any. On further questioning, she has abdominal pain, which is dull, and also noticed some dark starry stool in the pool, in her pool, as well. I could not able her to do like any form of autoimmune condition, no hair loss, no lumps and bumps in the body, no fever, and there's no joint affectation. She does not smoke nor take alcohol and does not have any medical history on examination. She's pale and jaundice. Pulse rate is normal as well as the blood pressure. She has distended abdomen, tummy with splenomegaly, as well. No ascites. A bowel was normal. I also want to do a digital rectal examination to assess this patient. Putting all of this together, I'm suspecting that this patient could have possibility with in him, Other things I want to consider will include a chronic liver disease, a chronic liver disease in her, the compensated chronic liver disease. Also, I also want to consider the possibility of possibility of a celiac disease in her as well, considering the rash and abdominal findings that she had. Those are the things I want to put as my differentials.
Okay. I will investigate this patient. So.
Okay. To investigate this patient first, I want to do a full blood count to include differentials and also peripheral blood film. As well, looking out for the neutrophil and any other forms, if there's any other forms of abnormal cell peripheral, like schistocytes and cytosis on the fragmented cell on the peripheral blood film. Then I also want to go ahead to do function test for her, electrolyte, urea, and creatinine. Also do pool tests, looking out for fecal capotectin. Also a fit test, fecal fit test for him, sorry. Then immunological test. Then I also want to do an abdomen other autoimmune screening will also be important in this patient. I also want to consider abdominal ultrasound to confirm the organ enlargement, the splenomegaly in her. Then do a CT abdomen, possibly a CT thoracic abdomen and pelvic. If malignancy, if indicated, then invite the hematologist to assess, consider for possibility of bone biopsy if that is appropriate. They also want to do some markers for pathological malignancies as well. Also do screening such as lactate dehydrogenase. Dehydrogenase will also be important in this patient. Then check for the vitamins as well. Thank you.
All right. Thank you very much. Okay. Fair enough. That was
Okay, still 30 seconds, Dr. Henry. I will ask here some questions.
Okay. All right.
You mentioned a study for if you suspect myeloproliferative. What are the specific investigation you can do?
Specific investigation for myeloproliferative disease. You can do the cell differentiation markers.
What else?
What can you do in myeloproliferative disorders?
Flow cytometry, is it important? Flow cytometry, right?
Flow cytometry, yes, is important in them, yes.
Okay, what else? If invasive.
Then bone marrow biopsy.
Perfect. So this is the invasive test will be diagnostic. Okay. Yeah, that's enough. Dr. Henry will comment, then I will comment.
All right, and thank you, Dr. Ayla. That was a good one, but like it is, I only have a comment to say. This question, it was diet 3 question, Nepal, came out diet 3 2025. It was written last month, this particular question. It was station 5 in diet 3, in Nepal. Actually, this scenario is station 5 usually a very, very difficult, not a straightforward scenario. Every station 5 usually very difficult. It's also a difficult scenario too. Although you tried, you were able to, this patient, you had the patient is complaining of a rash at the back with itching. You didn't talk more about the rash. You didn't talk about. You didn't ask of any. You didn't clack around the rash.
Okay.
You didn't talk. You didn't just go. Then also, you didn't have past surgical history. This patient has had a surgery before. He just missed it out. Even in your examination, you didn't check for any scar in your examination. I feel that those are big omissions, that would have helped you arrive at the diagnosis here. And then the patient had vasculitis. Yes, definitely. He has intense itching. That you can see that even the mark you saw was more of a scratch mark. If you look at the image very well, it's a scratch mark with intense itching. The patient had a surgery. I had a cholecystectomy in the abdomen.
Okay.
I think a year ago. So the scar is still there. Assuming you check with it. Also, your examination too was not. It's just fine focus. Yes, the problem is your one of your differential diagnosis is likely to be, yes, it's a COD case. The patient has primary biliary cirrhosis. He has itching, very intense itching that make it, once it's scratch itching, that in fact, majorly at the back, sometimes at the hand, but definitely the what that disturb him much is the one at the back. He had the issue of gallbladder stone, which was removed from the surgery that was done. From that as a surgical issue. As if he has had any issue, I've told you that I've done surgery, some years ago, and that's warranted me to remove this gallstone. Then this patient too, if you look at, he has mellitus too. Melena, he has evidence of portal hypertension, splenomegaly, thrombocytopenia, and varicose bleeding. Those are, with jaundice. Typically, your first differential you entertain may not explain all these features that this patient had. Your second differential, in a way, could explain, because you see CLD, but you just say CLD. Your CLD was it's an umbrella term. It didn't tell us what you are thinking of the likelihood of the CLD. You just mentioned CLD, in which, as a differential diagnosis, I will not take that. Just as you're just saying, heart failure without any. CLD is a broad term. It can be due to, hepatitis B, hepatitis C, alcohol, non-alcoholic. So primary biliary cirrhosis that had issue of gallstone, which about 25% of case of PBC, they may have gallstone. It's one of the features that they do have. He had the stone removed. He still have the itching was still there, fatigue was there. Jaundice started. Even the issue, the of yellowness of the eyes. To tell me when the jaundice started, he didn't mention that. So your systemic review was not that thorough, because you that thorough, you have gotten the jaundice from the history. And then that backdates or tell you, okay, if it's a recent jaundice, that will tell you, fine, most likely it's compensated liver disease. Yes, that he has. He didn't check for tremor in your examination, abdominal examination. Even your abdominal examination, to me, it wasn't that thorough, because he didn't go systematically for the abdominal examination. He didn't check for, definitely, he has, I said liver is not enlarged, but the liver shrunken. Yes. Liver is not enlarged, yes, but he did check if he asked if the liver shrunken. Because cirrhosis can the liver can be enlarged, it cannot be enlarged. It may also be reduced with splenomegaly. So vis-a-vis, fine, you consider the myeloproliferative disease beautiful, is a good differential here. Definitely with the low, he had two lineage that is down, platelet is down, hematology, the hemoglobin is down. It's a good differential to consider what, myelofibrosis, definitely, or probably myelo disorders. Although you consider myelo, but the white blood cell count is normal. So there's nothing, the only myeloid thing that is there is the platelet, anti-myeloid, because that's where the lineage is. Lymphoid, so it's the platelet. When you see, as when there's any white blood cell count that is reduced or probably enlarged, probably increased, then you can take, you want to consider any of this myeloproliferative condition, in which in this case, the white blood cell count is normal. There's nothing there that is affected. The spleen, fine. If you think of idiopathic thrombocytopenia purpura, beautiful. It's a very good differential here. The platelet is reduced. It's having what they call it, spleen. He has some bleeding disorders too, which he has for vasculitis, some purpurity crash behind. SLE2, like you said, is also a good differential here, but however, like you said, I like the way you read it out. No oral ulcers, which may not be having oral ulcers. But the acts of, your cardiovascular examination was not thorough to, at least you have picked some, maybe if you're having some magnetic murmur of the heart, some perhaps even the chest, to take the exam. Some, these are sometimes, those other systematic features may not be significant. However, like you said, it's unlikely to in this case, but you have to consider it. Despite the fact that he has bleeding disorders, which is seen in SLE. He had splenomegaly, which is seen in SLE. He has anemia, which is seen in SLE. There's some systemic review that is, you can still consider it as part of the differential and then rule it out. Then CML. CML may, definitely, although it may present with similar fatigue, if the platelets is affected, may also have similar features. Splenomegaly. So cause of splenomegaly, in this case, we also look at other causes of splenomegaly. I like to try to rule out other, if what do you call it, sore throat, infectious mononucleosis. Beautiful. Yes, it's differential diagnosis, but you rule them out with by absence of sore throat. Absence of you check for lymph nodes, lymphadenopathy. You check for lymph nodes, other lymph node.
No, I
Once
missed it.
you see splenomegaly, you have to check for other lymph nodes. If you see any spleen, you have to check for other lymph nodes to also rule out other lymphoid, lymphoproliferative diseases. I think this is just my only condition. By and large, it was a good, and that's also your management plan, because once you think of that's also so your management to get towards the chronic liver disease. That's where your plan to go to, not the other one. But by and large, it was a good presentation. Thank you, Chief Dr. Bazin.
Okay, thank you, Dr. Inari. So is it case for differential, you mean? It's not direct to CML or
the question is a case of PBC, primary biliary cirrhosis.
Primary biliary cirrhosis.
Yeah,
Okay.
the compensated chronic liver disease, secondary to primary biliary cirrhosis.
But
that's what the patient has. Yes.
Yeah, sorry, Dr. Inari. I remember Dr. Ayula asked you, do you think or anyone told you your eye is yellowish? And you denied that.
Okay. You asked me, Ayla.
I asked in history, but you thought they asked jaundice in examination.
Yeah.
Oh, maybe
So-
I didn't get it.
It's okay,
Sorry
no
for
problem.
that.
No problem. No, it's
But
okay.
in the examination, at least he mentioned jaundice for the examination. Okay,
Okay.
okay,
Good. Okay,
All
that's good. Okay, so it's a case of BBC as autoimmune again. And these are our differential. Myeloproliferative, lymphoproliferative, and autoimmune. The same differential. So the condition or the diagnosis will be different according to the name. However, the term is there, autoimmune, and primary biliary cirrhosis is one of the autoimmune. So it's a correct differential if you mention it. But since you have this jaundice, yes, you have to mention liver disease or obstructive or cholestatic liver disease. Yeah, I agree with this. Let's go back to
but looking at it, I said that is decompensated as what's called differential decompensated chronic liver disease. I think the issue was that
here the jaundice is not
cause.
related to the compensation. It's related to the liver disease.
The spleen that I picked.
Unless,
I was like, okay.
unless you have the other decompensation like ascites, like asterixis, the jaundice we have, and ascites, encephalopathy. You can say this is encephalopathy. However, if you feel the liver, if you palpate the liver, means that the liver is enlarged, not cirrhotic. So you can assume this is still not decompensated or still in the progress or in early stage. Okay. Anyway, I will comment about the constitutional symptoms. Fatigue, one of the constitutional symptoms. So you have to ask about the other constitutional symptoms along with it. Loss of weight, loss of appetite, night sweat, and night body temperature or high body temperature, right? If you have all of them positive, along with the fatigue, what do you think I add to my differential? And I should do? Screening. Dr. Ayula.
Okay, all of these tuberculosis.
Yeah, one of them, TB. What else? What other serious infection, we should have a history from it, from the patient to roll out them. Exactly. Risky habits in all situation you should screen. Started from the sexual activity. You have any casual relationships, any sharing needs, any tattooing, any piercing, any blood transfusion. Okay. You ask them?
No.
You ask?
No.
Yeah. And you can, and the examiner might minus you. Because
Okay.
he can ask you, or the patient might ask you one of the concern, Doctor, do I have HIV? It's a direct question, and you will be in trouble. You didn't ask about any risk habit. That's why my comment on the history that it went randomly. You are asking question up and down in this organized way. That's why you missed part, very important part in the history, which is HIV questions. The system review here, you can ask, I think you asked, but again, it was disorganized questions. Okay. The other thing here, the job. I think you asked about the job, right?
Mm.
Okay, family history,
Family,
travel.
he has family history. He has family history.
I
Yeah.
did ask. I asked.
Yeah,
If,
she
if he's
asked
married,
about family.
if he's married,
No, I didn't ask.
that's what I'm saying. He
Yeah,
has if he's married. I just wrote it down.
yeah, the female history is important.
Yeah, that's right. I put
Yeah,
it down, but
that's
didn't know why they asked. I
yeah,
wasn't like,
you have to be organized and systematic while taking history. The way I prefer is the package question. Whenever you start system, you do it from the head to toe. Constitution, ask them together. Do you smoke? Do you drink alcohol? Do you drive? What's your job? Together. As well as for the HIV question, all of them together. Why? Because if you ask one question in system and you deviated from this question or this package of question, you might not come back to this part and you might miss important clue. As in this scenario, you miss the HIV, which is very important to put, even if it's not that the case. But if you will say it as a differential, it will not minus you. But if you miss it, it might be the case and it might minus you. Agree?
mm-hmm.
So please, whenever you have constitutional symptoms, ask the whole HIV questions. Again, back to the examination. Here you have to examine the fatigue means something constitutional. So what I have to examine here, the lymph node which you miss. Very important. Apart from the splenomegaly or the myeloproliferative means liver and spleen. And the other peripheral signs of pallor and jaundice in the eye, and the abdomen examination should be full examination plus the lymph node. These are the three systems you have to examine. Okay. Okay, Dr. Ayula.
Yes, I'm with you. Yes.
Okay. Okay. Well done. I will ask Dr. Muhammad Omar because he wrote myeloproliferative, and I was agree with him. It's myeloproliferative because I didn't hear the jaundice. However, I will ask again, Dr. Muhammad. What do you think the case, Dr. Muhammad? Dr. Muhammad Omar.
Yes, Dr. Basim.
Okay. Yeah. What you put in your differential?
To be honest, also I didn't hear the jaundice during the
Yeah.
history, so I put myelofibrosis and I put HT.
Perfect.
Yeah, and also when she said the rash was itchy rash and was in the back, and when she mentioned that she had an operation before, I put also porphyria cutanea, to be honest.
Okay.
But
Okay.
but
What about, I
mm,
will discuss with you another differential could be there. What do you think the rash in the back could be? You can say, is it purpura? Do you think is it purpura?
it seems like telangiectasia from the
Okay.
from
Yeah.
the picture that she sent in the group.
Okay. If you have a splenomegaly along with purpuric rash, what the differential can fit here?
Myeloproliferative disorders.
Okay, myeloproliferative. What else? It's very important differential. In female, middle age, purpura, ITP. Yes.
ITV,
Yeah. So ITP also splenomegaly with rash, right?
yeah, yeah.
And it's autoimmune condition. I can say, and it will be presented as well with the fatigue and a platelet, of course, drop of platelet or thrombocytopenia and anemia. Okay, SLE, do you think can fit the differential away from the rash at the back? Okay, let's assume the rash in the face, for example. Can be?
Rash in the face?
Yes,
Yeah, it could be SLE.
SLE, exactly. So autoimmune hemolytic anemia with SLE.
Yeah.
Or even pancytopenia in SLE.
Pancytopenia with SLE. Yeah.
Exactly. Yeah. So still autoimmune is the big term you can put. And under the autoimmune, you can put a lot of differential. SLE, ITP, BBC, right? All
Yeah.
of them can be there. Plus, of course, for me, I think this case matching too much the myelobrotic disorder in the form of chronic myeloid leukemia because he has history of 6 months or she has history of 6 months. If we suspect HIV, what do you think this rash could be? Rash at the back or all the body with spleno and hepatomegaly? We suspect HIV. What do you think the rash will be there? What we call it, particularly 1 month after exposure. And it will be all over the body, not at the back only.
Kabushi sarcoma.
Kaposi sarcoma, it's one of the viral infection, could be as
Conversion.
opportunistic, right?
Conversion.
Yes, exactly. The other condition, seroconversion syndrome. So I mean the viral went inside the body in a large amount or a very high load. Okay. This is the differential today. For me, it's again good case, but one question might give you a different differential, like the jaundice. If you miss the jaundice, or if the patient is not having jaundice, your differential will be deviated away from the BBC to the myeloproliferative. By the way, you can put lymphoproliferative as a differential, but you have to have some lymph node enlargement. And what the cause? I will ask now, all of you, what is the cause of thrombocytopenia and anemia in lymphoma patient? Anyone knows? If I have patient,
Hypersplenism.
okay. One of the question, hypersplenism. What else?
Bone
One
marrow
of the answer.
Bone marrow filtration.
Perfect.
Infiltration.
Yes, as the myeloproliferative has lymph node spread, and the same for the lymphoma. It can spread to the bone marrow, and it can cause also bone marrow depression. The diagnostic test for the chronic myeloid leukemia is, all of you, the diagnostic test of myeloproliferative disorder. Non-invasive flow cytometry blood film, peripheral blood film, right? Looking for the cells and the shape of the cells and the nature of the cells, okay? And the invasive test will be
bone marrow.
bone marrow aspiration. Okay, for the lymphoma, the same flow cytometry and peripheral blood film, looking for lymphocytes.
Lymphocyte. Lymph node biopsy.
Exactly, lymph node biopsy. And again, bone marrow aspiration, it can help. Okay, particularly if there is spread to the bone marrow. Yes, I think we are done. The HIV screening, let's finish the all investigation. If you suspect HIV for a patient, what are the investigation for HIV? Anyone?
PCR.
Tell me
HIV.
Okay,
ELISA بالأول بعدين
perfect. Yes.
PCR.
Okay, tell me ELISA for what, PCR for what, and the third test is what? ELISA okay, P24 antigen. This is after exposure. You might have it after 1 month. And for the ELISA, what you will the ELISA for what?
will detect the antibodies against
Perfect.
the HIV.
Yeah, ELISA for
the
antibody.
PCR will see the viral load.
Perfect. PCR for viral loads. And in the advanced stage, how much? What you will do?
CD4.
Perfect. CD4 count.
Yeah.
In order to give the prophylaxis or the patient if he has susceptibility to have opportunistic infection, right?
Yes.
What else? Yeah, that's it. And the if you want to do you want to screen for the response, what you will do?
Response of what treatment?
Yeah. If you start
PCR
from
again for viral load
exactly
and
for
maybe
viral
CD
load.
for count
Yes.
also.
Yeah. So the for count and BCR for viral load. Yes, I think we cover the three. Let's talk about the topic itself. BBC, primary biliary cholangitis, right? Before they mention as cirrhosis, but nowadays it's cholangitis, right? Primary biliary cholangitis. What is the diagnostic tool?
It's autoimmune disease, so we should screen for autoimmune markers like ANA, and I will be positive. Also,
Okay.
IgM will be positive also.
Okay.
ARCV.
Yes, the diagnostic tool will be MRCP or ARCP, therapeutic and diagnostic. But MRCP can be initially, okay? If there is stone suspected or obstruction of suspected, you want to put stent, you can do the the therapeutic ARC. Exactly, yes. Yeah, so I think these are the most important tools and investigation. And the management, of course, you have to treat the cause or the underlying cause. For the leukemia, the chemotherapy, of course. And in the long term, definite treatment for leukemia and lymphoma is?
bone marrow transplantation.
Yes. For the BBC, what is the definite treatment?
Liver transplantation.
Exactly, if there is liver cirrhosis. And yes, I think we're done with the old HIV heart. Of course, you have to manage with high retroviral viral medication. Okay. Anyone has question or comment? Dr. Hina and Dr. Ayula, particularly.
Thank you very much. Like station 5 is usually a very difficult
Yeah.
stations. It's not typically like the other station. It's a quite kind of difficult scenario anyway. So thank you very much, Dr. Ayla, for that wonderful
Yeah.
time. Thank you very
So my
much.
advice to you, Dr. Hina, since your exam is next week, please don't feel panic whenever the case or the presentation or the complaint. Do your scheme, follow the approach you prefer. Everything will be there as a clue. It will help you. They are not malignant to hide. If you ask, they will tell you. Okay.
Mm.
But put in your mind, no, I have to catch the case. And sometimes, even if you miss the case or the diagnosis and you put it as a number two differential, the examiner can give you good mark for the approach.
Yes,
Okay.
sure. Thank you.
Okay. Anyone else with question? Yeah, Dr. Ashayma. I think the complaint of rash make the dilemma for us. Yeah, the rash, yeah, is little bit confusing.
Scratching marks maybe
Yeah,
because of
it was
itching
like
maybe.
yeah. But the question here in the history, as anyone told you, you are yellowish or your eyes being yellowish or any itching. Also, by the way, you can put itchiness as one of the constitutional symptoms. Why?
Mm.
Because it's guided you to something obstructive to the liver duct or hepatic duct and increase bilirubin. So it's not something normal unless or something benign, unless it's, for example, gallbladder stone. This is the only benign issue or only benign condition with obstruction or cholestatic features. Apart from the cholestasis of pregnancy, also something to be reversible.
Yeah.
But the others, sometimes with the autoimmune, PSCC and PCC, along with the ascending cholangitis, pancreatic cancer, all causes of jaundice are mostly malignant. So it's something alarming, you can put it one of the question of constitution symptoms. Put it in your list and your approach. Okay. Doctor, yeah, aplastic anemia, leukemia, vitamin B deficiency. It depends on the diet, habit, HHT, Dr. Muhammad. Yes, the rash looks telangiectasia, but family history wasn't there. No other bleeding, so you can remove it. For failure cutaneous tarda, as we mentioned, it will be sun-exposed rash, particularly with alcohol, some hair growth distribution. But again, it's not the case because maybe you were confused with the rash. The primary biliary cirrhosis, Dr. Shema wrote it, mashallah. I didn't see this comment. Perfect, Dr. Shema. What is the diagnosis? Yes, primary biliary cirrhosis. Thank you, Dr. Inai, Dr. Ayula. Well done.
Thank you so much.
Most welcome. Tomorrow, I have some social issue. If I can arrange the session, I will let you know. If not, we will have another meeting, or I will arrange for the next meeting maybe on Thursday. So I will tell you tomorrow, after tomorrow, if I can arrange. I will message in the WhatsApp group, and the one interested can tell me. Okay.
Thank you very much.
Okay.
Thank you.
Thank you, Dr. Hanif. Thank you, everyone. Thank you, Dr. Muhammad, Dr. Shema, and everyone attend today. See you, inshallah, with the next meeting. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.